Greetings. I'm Dr. Javed Butler, professor and chairman of the Department of Medicine at University of Mississippi in Jackson, Mississippi. Delighted to give this presentation on the enablement of RAS inhibitor therapy using the novel potassium binders. What is the available evidence? My disclosures are at the bottom of this slide. So let's first frame the problem quickly. First, RAS inhibitor therapy, both for patients with heart failure, chronic kidney disease, and other cardiovascular diseases like myocardial infarction, diabetes, is really cornerstone for therapy for these patients. If you look at specifically with the lens of heart failure, we have trials after trials with ACE inhibitors, ARB, angiotensin receptor, neprilysin inhibitor, and mineralocorticoid receptor antagonists in patients with mild, moderate, severe heart failure and post-MI patients that have shown benefit with these therapies overall in the entire population, or at least in subsets of the population. Not only is it important to give these therapies to the patients, we have also learned that giving higher doses, the doses that were attempted in the clinical trials, lead to improved outcomes beyond just giving low dose therapy. And finally, we have also seen data from observational studies that the combination therapy provides you with the best possible outcome for these patients. So in summary, what we know is that we need to give these therapies to the patients, we need to give the combination therapy to the patient, and we need to give therapy, which is at the dose that was given in the clinical trial. So there are three layers for optimal medical therapy in order to improve the outcome for these patients. The problem is that the patients that develop hyperkalemia are the ones that are at the highest need for these therapies as well. So your older patients, patients with heart failure, diabetes, chronic kidney disease, and these things tend to occur in clusters, not necessarily in isolations. And on top of that, if you add medications across the spectrum of RAS modulation, all of these drugs also cause hyperkalemia. So ACE inhibitor, ARB, ARNI, and MRA, but a lot of us sometimes forget that beta blockers also cause hyperkalemia as well and has RAS modulation properties as well. So now you're really sort of stuck if, as a clinician with this conundrum that all the therapies that are good for the patients have this side effect. So what are the data in terms of the association of the risk of hyperkalemia, and how do clinicians react to medical therapy when patients do develop hyperkalemia? So this is a slide that shows us the incidence of hyperkalemia in clinical trial setting. And then these are some of the data from practical observational data, real world data, registry data. But first, remember that the clinicians react to hyperkalemia not in the classic sense that your potassium is greater than 6 or you have changes in the EKG. Clinicians react to hyperkalemia at a much lower level because they want to prevent bad things to happen from the patient. So that's one issue. The second issue is that hyperkalemia in all of these studies, whether clinical trial or observational studies, somewhere between 15 to 25% of the patients may develop hyperkalemia in these studies, more so if you have a combination of chronic kidney disease and you're using mineralocorticoid receptor antagonists. So that's the group which is the most vulnerable. About 25-30% may develop. If you're just using ACE inhibitor and you don't have advanced CKD, maybe the range would be 5 to 10%. But remember that all of these studies are time limited, right? So you have a study for 1 year or 2 years follow-up, whereas these therapies that are needed are lifelong therapies. So as you give the therapy, the risk cumulatively increases as comorbidities accumulate, as comorbidities worsen, and as individuals age, and just aging-related GFR drop occurs as well. So in some sense, the impact of hyperkalemia is significantly underestimated these studies, because these studies are relatively short-term. And as I mentioned, all of these comorbidities and other conditions that put patients at high risk for hyperkalemia tend to be together as well. The other issue is that hyperkalemia tends to be a chronic problem. And this is probably the number one issue in the cardiovascular medicine, is that we don't think about hyperkalemia as a chronic problem. What ends up happening is somebody who develops hyperkalemia Very rarely, it is an entirely reversible cause, right? So somebody has, inadvertently took more potassium supplementation or took, high doses of non-steroidal anti-inflammatory drugs. More often than not, it's the phenotype of the patient, diabetes, heart failure, aging, kidney disease, that puts you at high risk for hyperkalemia. And one episode is followed by a second episode, is followed by a third episode, because again, that phenotype that develops heart failure doesn't change. So what do clinicians do? Well, first, do no harm. So clinicians do what they are told to do, and that is to stop the RAS inhibitor therapy. Now, what ends up happening in nephrology practice when your GFR is really low, that even stopping RAS inhibitor therapy, these patients tend to get hyperkalemia. So nephrology community sees hyperkalemia as a chronic problem. Cardiology community does not. What happens in cardiology is that you develop hyperkalemia, you either significantly reduce the doses or you altogether stop the medication, and hyperkalemia goes away. Except that in the next 6 months, year, 3 months, whenever the person's comorbidity gets worse, they develop worsening heart failure, or they show up in the emergency room short of breath, their potassium levels are normal. But we never considered that as a consequence of hyperkalemia, because hyperkalemia led to stopping the good medical therapy. And we just basically said that's the natural history of the disease. These are some sort of remarkable data showing that although the guideline recommendations are to reduce the dose of reduce the dose of RAS inhibitor therapy if somebody's potassium levels are between 5.5 and 6, and to stop it temporarily over 6 till the potassium comes down. In clinical practice, even if you have mild hyperkalemia between 5 to 5.5, as is seen here, almost half of the time the clinicians lower the dose or stop the medication. And that makes sense, right? So one is you don't want to wait for things to get worse. People try to react. You don't want somebody to have sudden cardiac death. But the other thing is that there's a huge social factor here as well. People, older people, they may not have somebody to help them bring for clinical appointment. They may not have home health. They live too far away that you cannot reliably do repeated blood measurements. So what's the easiest thing to do? Easiest thing is to stop the medication. The problem is that when we lower the doses of RAS inhibitor and when we stop the RAS inhibitor therapy, we are effectively exchanging a short-term problem for a long-term problem. And that leads to this whole issue of how do we enable medical therapy and really not compromise between one or the other option. Now, we have a lot of good therapies to treat acute hyperkalemia, right? We can push the potassium into the cell. We can use insulin, glucose, bicarb. We can stabilize the membrane by giving IV calcium, reduce the risk of arrhythmias. The question is, what then? So you have done all of those things. The potassium levels have been normalized, but now this patient is at a higher risk and you're about to compromise RAS inhibitor therapy. What do you do then? Well, we really don't have any options, right? So you cannot just keep pumping more and more diuretic therapy, especially in these patients with blood pressure issues and kidney and GFR issues. SBS is very poorly tolerated just in terms of GI side effects, but also some serious side effects like colonic necrosis, and also is not well tolerated in terms of taste. And there are really no good options. There is no way to optimize RAS inhibitor therapy on the basis of diet alone. First, high potassium diet is actually good for you from a health perspective. Two, you cannot optimize RAS inhibitor therapy assuming that the patient will have a strict diet 7 days a week, 3 meals a day, every single day of their life. And then the third thing is that these are multimorbid patients. So what do you recommend to them? Low sodium diet for heart failure, low potassium diet for hyperkalemia, low lipid diet for coronary disease, low glucose diet for diabetes, right? So it starts becoming pretty complicated and impractical. Well, in that sense, now we at least have two novel potassium binders, sodium zirconium cyclosilicate and pitoramer. Sodium zirconium cyclosilicate is acts across the GI tract, exchanges sodium for potassium, lowers serum potassium levels, and has more GI excretion of potassium. The sodium, whether or not that's an issue, is debated. At the doses where most of the hyperkalemia is resolved, maybe the sodium load is not too much, but when higher doses are given, especially to our patients with CKD and heart failure, where high sodium is something to be avoided, that is something which is debated. Again, very good data that there is a dose-dependent reduction in potassium levels, and they normalize. And what's very interesting about these potassium binders, both of them, sodium zirconium cyclosilicate and patiromer, is that the potassium level kind of comes down and they stay at around the mid-4 range. And the chances of overshooting and causing hypokalemia is very, very low. Remember, our talk today is focused on hyperkalemia, but hypokalemia is equally risky in terms of the outcomes. But overshoot is very uncommon in these patients, and body's own homeostatic mechanisms come into play, and you're sort of at the mid-4 range. Now, what is interesting is because the phenotype doesn't change for these patients, these studies are about 1-year studies. And when you stop the patiromer or sodium zirconium cyclosilicate at the end of the year, when the study is done, you can see that in 2, 3, 4 days, hyperkalemia starts coming back because that phenotype has not changed as is seen here. Patiromer is another novel potassium binder. It exchanges calcium for sodium, so it does not have that sodium load issue. It acts primarily in the colon and not all across the GI tract. Also pretty well tolerated as sodium zirconium cyclosilicate. Again, exactly the same profile, very well controlled potassium levels, well tolerated. And towards the end of the year, when you end the study and when you stop these therapies, potassium level starts going up. Now, there are 3 studies that have looked at enablement with the use of these binders. So these are 3 studies with patiromer. Patiromer is the only one between all the potassium binders where there were targeted studies done looking at enablement per se. So OPAL-HK was in CKD patients. It was a secondary outcome, and one can see here substantially better RAS inhibitor use. By the way, these trials were very well represented in terms of all common comorbidities. So you have your older patients, your diabetic patients, your patients on high-dose RAS inhibitors, your patients with heart failure, CKD, and the magnitude of potassium reduction and the efficacy of potassium reduction was seen across all of these categories or the combination of these comorbidities and other risk factors per se. So the effectiveness was seen. But in terms of the enablement, the second study is PEARL-HF, as is shown here in the middle. This was in heart failure patients, HFrEF patients who could not tolerate RAS inhibitors, particularly MRA, because of hyperkalemia. Again, there was a significant increase in the doses and tolerability of MRA with the use of patiromer enabled RAS inhibitor therapy. And granted that there was significant tolerability here as seen in the placebo arm, but remember, this was a very short proof of concept 4-week study. And even in such a short 4-week study, there was a 25% difference, 15% difference in potassium tolerability and use of spironolactone. And then the third study is the EMBER study, which came out in Lancet. And again, a short-term study, but a little bit longer than PEARL-HF, which was about 12 weeks a study in resistant hypertension, where we know that MRA is the drug of choice for resistant hypertension. And again, better potassium control and enablement. So now we have targeted enablement data as well, but relatively short-term, 4 weeks and 12 weeks. Well, in that sense, we have the large trial called the DIAMOND trial. This is the largest enablement trial that is done with longer-term follow-up. So the study has not been published. We don't know the data, but the study has completed. Because of COVID, there was a lot of difficulty in completing this study. So the study had changed its primary endpoint, but nevertheless, it's the largest trial. And we did get a press release by the company that the primary endpoint of the trial was met, which was better potassium levels, as well as enablement was seen in 85% of the patients. So these are the only two results we know right now, but the detailed results and the enablement of RAASi and all of those secondary endpoints will be presented at the ACC meeting in the next 4 weeks. So we have to wait for that. So to summarize, we have now 2 potassium binders that can control potassium levels, are safe, are well tolerated, and indeed the ESC HFA guidelines and now the European Society of Cardiology guidelines are both recommending that potassium levels should be controlled and that these novel potassium binders can help both treat chronic hyperkalemia and optimization of RAASi therapy. And also kidney guidelines, KDIGO, are also giving the same recommendation that before we cut down the dose of these therapies or stop the therapies, managing hyperkalemia with the use of novel potassium binders may be preferable. So thank you very much for your attention. And this was a lot of information, but I hope it was of use to you.